First of all, I want to thank again my good and old friend Professor Santos that invited me for this nice meeting that is growing and growing in your country. We have the same in Italy, and we think that this is a good way to have in all Europe a good education in the field of wound healing. This year I was invited to share our experience in pressure ulcers. We know that pressure ulcers are most common in elderly, but not only. In young patients, we find this ulcer after spinal cord injuries. And 85% of patients with spinal cord injuries has this problem almost one time in their life. But we have to remember that this kind of ulcer can be very dangerous because 3% of them can have an evolution in severe systemic complications like sepsis. So what is important? The implementation of a monitoring program and the extension of prevention measures, that it's the very gold standard that we have to develop in such field in order to reduce health and costs too, that it's a very huge actual problem. In elderly patients, we see pressure ulcers, especially in the sacral area, because it is the commonest one affected by bedridden patients. On the other side, in younger patients with spinal cord injuries, we have the sites in ischiatic area, sacral area, and trochanteric area, where the cubitus is concentrated. Which are the stages? We know the classical classification, and for every stage we have a measure of prevention and therapy. The stage 1 is important. Every time that one patient shows to you an intact skin area with fixed erythema in an area of the cubitus, pay attention to this sign, especially if the erythema don't disappear with acute pressure. What we can do? Something that is very important in terms of prevention, like postural hygiene, the active-passive mobilization of these patients every 20 minutes. Every 20 minutes, these patients must change the cubitus to permit to the microvascular network to recur and to return to a normal situation. The muscle strengthening, the massage, and sometimes ultrasounds as external therapy. On the second stage, we see down to the dermis a partial thickness loss. In such patients that arrive directly to the attention of doctors and nurses, we have an open ulcer with a red-pink wound bed without slough. In such kind of pressure ulcer, we need the same prevention measures, and here begin the local therapy with advanced measurements or local oxygen therapy arriving till the hyperbaric chamber. But at the third stage begin the action of surgery, because maybe at the third stage we have a full thickness tissue loss, which means necrosis of subcutaneous tissue. If we want to have a level, we have to remember that this lesion can be extended till the fascia without passing it. So we can see the the tissue loss in the underlying skin tissue that arrive till the muscular fascia, and in such case, unfortunately, maybe local therapy is not enough, and it's a lose of time sometimes to insist with advanced therapy. From this moment, the surgical treatment begin with a wide debridement and then with a surgical proposal to these patients. But what is dangerous is the fourth stage, in which we have a full thickness tissue loss with an extensive disruption of tissues and necrosis that is extended to tendon, joint capsules and bones. In such patients, many times we have osteomyelitis, and these patients need surgical therapy as soon as possible. Why? Because we can have huge infective complications, so it's important to have a scheme of treatment that pass through skin swab, urine culture if the patient has fever, periodical blood culture if necessary, and the laboratory checkup with the count of neutrophils, VES and PCR. Why? Because sometimes we are in front of gram and streptococcus and Enterobacteriaceae infection, and in sometimes nowadays, especially if the patients were treated for a long time, we have the multi-resistant infection that is one of the main problems that we have nowadays in our departments. So, from this moment, it's very important the collaboration with the infectivologist, because this patient will go through a very sophisticated antibiotic polytherapy that consider all these factors, even the possibility to have a multi-resistant. The radiological exam can helpful the clinician, X-ray, TC, but what is a new proposal, it's the PET-TAC, that it's a specific exam that helps you to recognize if you have an osteomyelitis inveterated, and that can help you to see the level of this osteomyelitis. This is more than we had in the past during the scintigraphic exams. And here you can see an example of this PET-TAC in which the PET image is overlapped with take image. At this exam inform you about the exact anatomic site that metabolize the drug. In such case, you have from the beginning the exact idea that in your patients maybe you have an infection to the coccyx and the large sacral vertebral level, and so you can plan a huge and radical surgery with the reconstruction after this that must be performed in such kind of patients. So, the necrotic tissue careful debridement, the carefully well done fistulectomy, and the wide osteotomy if bone tissue is involved is the gold standard of these patients. That this surgery can be followed by negative pressure therapy, and nowadays in my department we have a very huge new enthusiasm with installation that is performed in these patients if we can perform immediately the reconstruction. Reconstruction that pass through different surgical procedures that we can see. Flaps, all of them are flaps. Here you see a very important patient with sacral and ischial left ulcers. These patients were subjected to a debridement, a huge debridement, and the treatment with instillation with negative pressure. In such kind, we used an antiseptic solution because we have the help of the infectivologist that suggests to us which kind of solution was better to use. And then we went on with a second surgical procedure with two different kinds of flaps, a myocutaneous gluteal flaps and a bifemoral and a biceps femoral myocutaneous flaps, solving this dramatic situation. These patients arrive in a septic condition at the admission at our hospital. When Professor Santos asked to me to speak about this topic, it was the opportunity for me to reflect for our 42 patients treated by pressure ulcers in my department, all of them treated with reconstruction with flaps. And so, from this reflection, we'll see some elements that are very important nowadays, and it was an occasion for me to reflect on what has changed in the last 5 years of treating. And then, at the end, what is very new proposal, that it's the preventive lipofilling. We treated till now 7 patients with a new surgical proposal that it's to do in the same time of the flap surgery the lipofilling in healthy areas at risk of ulceration. Consider that many of these patients had a second recurrence or another ulcer during their life because they begin to be treated very young. In fact, you see that we have patients even at 17 years old treated. Most of them are males, in accord with what Annette told about men, and the middle age was 51. Many of these patients were paraplegics, 14% quadriplegics, and 1 patient had a cerebellar syndrome. So we must consider that these patients are complicated even in the wound healing condition. Why? Because we don't have the neural control of wound healing, and for this reason the treatment of these patients after surgery is more complicated, and the follow-up is very strict in these patients. They stay in special beds, the clinitron beds, for at least 3 weeks to control the sutures, because we know that wound healing in such patients is complicated. We see here that most of the ulcers that we saw were ischiatic, 30% sacral, 10% trochanteric, and most of them were 4 advanced stages. At the Department of Plastic Surgery arrived patients with the program for surgery, patients that you must send, the nurses and the doctors must send when they say a 3rd or 4th degree. And in these 42 patients we use many different reconstructive techniques, and you see here gluteus flaps, femoral biceps flaps, gracilis flaps, superior gluteal artery perforator flaps, paravertebral flaps, the latissimus dorsi used as a turnover flaps, the tensor fascia lata flaps, and posterior tight random flaps. Why this slide is important? Because from here you must understand that the plastic surgeon must know the anatomy of this area very well, because if in the past we used 3 kinds of flaps or random flaps, nowadays the surgery is changed and we are using more sophisticated techniques, which is the revolution in the treatment of these patients. The possibility to use the perforator sparing buttock rotation flap. What does it mean, this? You can see here that we check and we find the perforator artery that permits to mobilize a flap that is done of skin and the tissue under the skin without using the muscle. This is a very revolution in the surgical treatment of these patients. Why? Because we leave intact the muscle, or the damage that we do at the muscle is not so important. And this in the concept that maybe we will need the same muscle in the future for a recurrence or for another ulcer that can occur in such kind of patients, arriving to an elegant and stable closure of this ischiatic ulcer. Or such in these patients, we use in the presence of sacral and ischial pressure two kinds of flaps, a traditional myocutaneous Ypsilon flaps and a gluteal fasciocutaneous flaps that was a perforator one. So sometimes we can put together different surgical techniques to obtain in one single operation the stabilization of a very huge situation with a double ulcer. Why we understood that this sparing surgery is important in such kind of patients? Because nowadays we know better the anatomy and the vascularization of gluteal region, and we know that in our patients we can perform different flaps based on the inferior gluteal artery or in the superior gluteal artery. So knowing the field that are vascularized by these vessels, we can perform different flaps with the conception of muscle sparing. And the radiologist helps us studying the perforators with the angiotac, that it's an exam that it's used in the projecting part of such kind of surgery. And here you see another patient treated with a superior gluteal artery flap for an sacral decubitus, a 19 years old patient, in which we are obliged to do such kind of patients to spare the muscle that will be useful in the future if he will have other problems such this. Or here you can see that in presence of severe bilateral ischial pressure, sometimes we use both technique. After a very well conducted fistulectomy that you see here, you must sure to remove all the fistulas, otherwise if you leave granulation tissue there, you'll have a recurrence. You can do both kind of surgery, the traditional one with the retro-tight muscle flap and the use of the buttock perforator rotation flap. Or sometimes the myocutaneous flap as a second choice, like in such patients that has a recurrence on the left side and in which, in presence of a new fistula on the left ischium, we were obliged to use a traditional myocutaneous flap of biceps femoral. Or, such in these patients that has a third recurrence of sacral decubitus, in which we use the traditional surgery with a double myocutaneous flap that were definitively repair the middle area in the sacral area. On the trochanteric left, unfortunately, we don't have any news, and the traditional myocutaneous flap of tensor fascia lata is nowadays considered the gold standard for such kind of patients. Fortunately, the fascia lata is very long and the muscle can be moved without any important second damage at the abdominal area. But complications in such patients are behind the door. In these 42 patients, I recorded 15% of complication, and going back to the literature, I saw that complication arrived till 30%. More of these complications were dilations due to seromas, hematomas, or due to the lack of control of the neurologic vascular control in the site due to the plagic situation. And then the polymicrobial infection with Pseudomonas, Acinetobacter, Klebsiella, that sometimes can be really a dramatic situation. And the recurrence were more in the ischial region, that it's at the high risk. These patients has a follow-up of 27 months. So, what is the new proposal? The prophylactic surgery with autologous fat graft. I think that in such kind of patients, if we know the risk that they have to do a second or a third ulcer in their life, it's important to study the area at risk and to use what now is a new opportunity in the hand of plastic surgery, the autologous fat graft, for both direction. The tissue regeneration phenomena that we see in the area where we put the autologous fat graft, and the volumetric expansion of the subcutaneous tissue. So we decided to treat these patients to check the skin color of the high-risk area that was in healthy condition, the trophism and tone of the muscle of that area, the thickness of the skin and the subcutaneous tissue, the presence or absence of facial tissue. So these patients are studied with an echography and with a PET scan of the damaged area. The technique was the lipofilling following the Coleman techniques, and the controls were at 3rd, 6th and 12th months. All the patients were treated with the lipofilling during the main surgery of treatment for an ulcer. Why? Because nowadays the National Health doesn't pay for a preventive program in such kind of patients. It's difficult to convince our politicians to spend money in prevention, you know, and so we decided to treat healthy area, at-risk healthy area in patients that were programmed for surgery for the presence of a 3rd and 4th degree ulcer. You see our first studies now arrived to 10 patients treated, and we use a quantity of lipoaspirate that have an average on 40 cc. And the follow-up nowadays is at least 2 months, maximum 10 months, so we are at the beginning of the study. But in patients with huge ischial and sacral ulcer like this, we decided to perform on the healthy right level lipofilling, as you can see here, putting 90 cc on the contralateral ischial area, the adipose tissue. The repair was obtained with the technique that I presented before, and here you can see the control even in the treated area with the lipofilling. And how we are following these patients? With the ultrasonography study, that is demonstrating to us what happened in this at-risk area, like the scompensination of the fascia, or in such patients the presence of fatty cysts. But what we'll study more will be the vascular changes that we have in this at-risk area. Another patient treated on the right side, lipofilling on the right, and flat fasciomyocutaneous island of gluteus maximus on the left. And the control at the 3rd and 6 months, in which we see that the thickness between epidermis and bone surface passed from 4 millimeters to 10 millimeters. And this is a very important date in terms of prevention. Another patient treated on the left with a buttock rotation flap, contextual with an 80 cc of lipofilling on the right. And another one with a trochanteric ulcer that were treated with a myocutaneous flap of tensor fascia lata and a contextual 50 cc lipofilling on the other side. Another case, 40 years, lipofilling on the left ischial region during the treatment of a severe decubitus sacral and ischial ulcer with gluteal myocutaneous flap and an ischial amiflap. And the last one, the treatment of an ischial ulcer in a paraplegic with a biceps flap with a contextual lipofilling of 90 cc, the control at 3 months. In conclusion, we think that the pressure ulcer reconstruction surgery nowadays is changed, and we have to consider all the sparing technique that a good team of plastic surgery must have in his hand to do the sparing muscle technique, especially in young patients. These techniques are based on anatomic studies that say the gluteal perforator vessels. The second thing is that surgical planning must do in the most accurate and appropriate study, even using the PET TAC that can do very useful, especially for patients with osteomyelitis. The last things is that I think that in Europe we have to consider, and it could be interesting to do a multicentric study in the use of lipofilling as a treatment to prevent the recurrence of this kind of ulcer. Thank you very much.